So good to go.
Yeah, Akash. We can start.
So the greening to everybody present. Uh, this is basic module of critical care medicine, and I am Akash, the moderator for today. Today's topic is on septic shock, and we have a we have a presenter today. We have Dr. Abde Hussain with us, who is the speaker today. Dr. Abde has over 4 years of dedicated experience in critical care and also hands-on experience in ECMO dosing, TDM, CRRT. He has also spearheaded the antimicrobial stewardship program for Kingsway Hospital in Nagpur and also has experience in pediatrics and neonatology specialty. So welcome, Dr. Abde. Can we move to the first slide? So there are some participant guidelines with us that we have. So, so please post your questions or responses in the comment box and click the submit button. Your questions will be discussed during the question and answer session at the end. Next, please. Your feedback button will be available below the comment box, and your feedback form will be disabled after this live session. So do give your valuable feedback for us in order to improve the forthcoming modules even better. Next, the participants' certificate for this webinar will be issued within 14 days after attending this live event. If you are watching the event on YouTube, please log into the FCPI website and register for the event to claim your certificate. The participants can also download this particular presentation slides from the FCPI website also. For downloading the slides, login is mandatory as far as to download the file. So, Dr. Abdi, you can please take over for this presentation.
Yes. Thank you, Akash, for the kind introduction. So this is the third presentation in the subset of shock that we had started. So the basic module in shock. So first hemorrhagic shock and now septic shock. So no disclosures from my side. And what are we going to learn today? So first one is what is sepsis? It's epidemiology, the pathophysiology of sepsis and septic shock. How can we identify sepsis? Then management, in which we'll be learning about the choice and timing of antibiotics, the fluid resuscitation, the initiation and choice of vasopressors, role of steroids and other remedies in sepsis. So sepsis definition. So sepsis has been and always been a challenge. The Egyptians, the definition of it also has been a very big challenge. The Egyptians were the first to articulate sepsis. The Greeks denoted sepsis as a rotting flesh. And as the understanding of the bacterial infection increased, the definition was also further modified. Like in the 1970s, it was considered as a pus-forming organism in the bloodstream. So, in the 1970s, a small RCT was conducted to evaluate the effects of methylprednisolone in sepsis patients, from which it was identified that the host response is a crucial part of sepsis and which needs to be targeted. The investigators also proposed a diagnostic criterion for the sepsis syndrome, which comprised of a temperature more than 38 degrees Celsius or hypothermia less than 36 degrees Celsius, a heart rate of more than 90 beats per minute, a respiratory rate of more than 20 beats or mechanically ventilated patients, or for presence of one of the following, either altered mentation, hypoxemia, elevated lactate, and oliguria. Although the trial failed to show any benefits with the use of methylprednisolone in sepsis, and the blame was put on the trial design and diagnostic criteria rather than the intervention that was used. So further, after this dissatisfying sepsis syndrome criteria in 1991, the American College of Chest Physicians and the SCCM Society of Critical Care Medicine conducted a conference to define sepsis. They defined sepsis as the systemic host response to tissue invasion by an organism. Severe sepsis was defined as a sepsis in association with organ dysfunction, and septic shock was proposed to describe cases of sepsis with hypotension. Also, the SIRS criteria was defined as a clinical syndrome of systemic inflammation independent of its triggering cause. The SIRS criteria had addition to the previous sepsis syndrome of fever, tachycardia, and tachypnea, which consisted of hyperventilation with a PaCO2 of less than 32 mmHg, leukocytes either more than 12,000 or less than 4,000, or with more than 10% immature neutrophils. So in 2001, they expanded the set of criterions to define SIRS. Thus, the PIRO model was introduced that was based on the hypothesis that the patient with sepsis requires independent consideration of baseline predisposing factors, both genetics and acquired comorbidities, the nature and site of the infection, the nature and magnitude of the resulting host response, and the presence, type, and degree of organ dysfunction. So from this diagram, we can see there are so many mixed components of the SIRS that can happen not only in sepsis, not only in non-infectious based diseases as well. So in cases of trauma, burns, and pancreatitis, the SIRS is present. So again, it is a difficulty to differentiate between sepsis and these conditions. So finally, the third international consensus definition for sepsis and septic shock that occurred in 2016 defined the term sepsis as the life-threatening organ dysfunction caused by a dysregulated host response to infection. So this was undertaken by the North American Society of Critical Care Medicine and the ESICM. This eliminated the need for the terminology severe sepsis and shifted the focus from the concept to its clinical consequences, such as organ dysfunction. The conference also defined septic shock as a subset of sepsis in which profound circulatory, cellular, and metabolic abnormalities associated with a greater risk of mortality than with sepsis alone. So again, here the term eliminated was severe sepsis. So looking into the epidemiology of sepsis. So sepsis has been a global health problem that has been affecting millions of people every year and is a leading cause of critical illness and death. Furthermore, patients who survive sepsis often experience long-term physical, psychological, and cognitive impairments, known as the post-sepsis syndrome, which leads to diminished quality of life and loss in productivity. In 2017, the WHO made a sepsis a global health priority and urged member states to implement appropriate measures to reduce the human health and to reduce the human and health economic burden of sepsis after looking at the numbers that was produced by the Global Burden of Disease study, which estimated there were at least 48.9 million sepsis cases globally and was contributing to the 11 million deaths globally. That is 20% of the total deaths. In cases of India and other LMICs, the situation was even worse. In India, 11.3 million cases alone, with 2.9 million deaths, contributing to 25.6% death. So you can, as we can compare, the LMICs fared even worse than globally. Diarrheal diseases and lower respiratory tract infections were the leading cause. So next, coming to the pathogens causing ICU-acquired infections. In comparison, gram-negative bacilli constituted the most prevalent group of nosocomial pathogens in these ICUs. The most common single pathogen causing ICU-acquired infection in LMICs were Acinetobacter baumannii, P. aeruginosa, and Klebsiella pneumonia. These cause the majority of the infections. This distribution of pathogens is significantly different from the distribution of pathogens causing ICU-acquired infection in the Western European countries in the same period, where these same three species caused less than 25% of all the infections. In the European setting, gram-positive pathogens were more prominent, and the group of other nosocomial agents of ICU infections was larger as compared to the Indian setting, where the gram-negative sepsis predominates. Now, again, these data has been collected from only those areas where high income countries and where proper data collection has been present. So there are a lot of gaps in the data collection as well. Now, another issue with sepsis is the use of antibiotics and the rise in resistance. So the rise in resistance pattern is an increasing concern, and almost all isolates from the LMICs were resistant to multiple classes of antimicrobials, as we can see here. And the problems are difficulty in treating these resistant bacteria. There is such a stark difference between the resistant pattern in certain European countries as compared to India, and hence a challenging task in battling sepsis. So now coming to the pathophysiology of sepsis. So what happens in sepsis? There are four physiologic changes that are getting affected in sepsis, which are the immune system. Either it can cause hyperinflammation or immunosuppression, or both. In initial steps, it can cause hyperinflammation and subsequently immunosuppression. Second comes the endothelial dysfunction, leading to hyperpermeability and also known as the capillary leak syndrome, followed by vasodilation, which is resistant to the vasopressors that we give or the fluid challenges that we give. And the fourth is subsequently coagulopathy. So immune response in sepsis. As we can see from here in the figure, there can be either hyperinflammation or immunosuppression caused by the sepsis or the invading pathogens. So more the hyperinflammatory response, it leads to mortality. And subsequently, uh, immunosuppression in the severe stage also can lead to mortality. So there are two components of the human immune system that respond towards sepsis. These are the innate and the adaptive systems. So the innate system is the first line degree against the invading pathogens and acts rapidly and non-specifically. The adaptive immune system, in contrast, is much slower to respond, but is capable of recognizing unique antigens and utilizing immunological memory to enhance the immune response following subsequent exposures of the same antigen. In the innate system, there are natural killer cells, mast cells, eosinophils, neutrophils. The adaptive immune system relies on fewer cells to carry out its operations, and these are the lymphocytes, namely T cells and B cells. The T cells is further divided into T helper cells and T killer cells. In sepsis, the functioning of the adaptive immune response is disrupted and dysregulated, leading to improper defense against an infection. And increased death cell that is also present, which leads to the depletion of the immune cells, which can further mount for the subsequent infections. Now, these inflammatory responses also activate the coagulation cascade. So, again, what are the mediators that take part in the sepsis? So pro-inflammatory cytokines that are well characterized in sepsis include the IL-1, 6, 8, 10, and 12. So these are the pro-inflammatory, whereas 10 is a non-pro-inflammatory. So a lot of studies have been tried to target these cytokines and chemokines as a damage control in sepsis and also as prognostic factors. These chemokines play a crucial role so that they can affect various organ systems such as the vascular system, cardiac, respiratory, GI, etc. So let's see how they affect. So initially in the normal stage, the endothelium is an intact structure, but because of the inflammatory reaction towards the bacteria, the the immune cells release a lot of mediators. So like we already seen the cytokines and chemokines, this leads to the breakage in the intact structure of the endothelium, and the fluids escape out from the capillaries. So what are the consequences of this capillary leak? First is the pitting edema, ascites, whichever the site is affected the most. So there we see the fluid leaking out. If it is lungs, it will be seen in the format of pulmonary edema, either pleural, which can lead to either pleural effusion, or it can precipitate ARDS, acute respiratory distress syndrome. In gut, if the epithelium is broken, it can lead to bacterial translocation and secondary infections. In kidneys, the kidney functioning is deranged and can lead to acute kidney injury. And in brain, because of the breakage in the barrier of BBB, so it can lead to cerebral edema. And also because of the toxin accumulation, again, cerebral edema can cause. So after the escape of fluids and due to the vascular loss, the second part is vasodilation that occurs. So hypovolemia is capillary leak reduced to reduced intravascular volume, and the cardiac dysfunction that occurs because of the reduced volume that is there, which can lead to reduced preload, leading to reduced cardiac output. The inflammatory mediators also have effects on the cardiac function, and we can see cardiomyopathies developing. The peripheral vasodilation occurs due to loss of smooth muscle reactivity that is not responsive to naturally secreted vasoconstrictors. So these vasodilators are nitric oxide, prostacyclin, and in subsequent stages, vasopressin deficiency can ensue. Now, what are the hemodynamics and changes in septic shock? So we have seen that in a hypovolemic shock, cardiogenic shock, various changes in the distributive shock, the CVP is low. This is because of the loss of volume that occurs because the volume has changed from the intravascular to the extravascular space. The cardiac output initially is high, but can reduce subsequently because of the effects of sepsis. The systemic vesicular resistance is low because of the vasodilation. So the last and final thing that we again see in sepsis is coagulopathy. Because of the pathogen-induced immune response, it leads to the platelet activation. The breakage in the barrier again exposes the endothelium to various clotting factors, which can again interact with platelets and activate them. This initiates a clotting cascade activation, which leads to the formation of microthrombi, which can further block the blood supply to various organs and tissues. Because of this microthrombi and the initiate fibrinolysis. So the fibrinolysis starts and leads to the consumption of platelets and the factors. And subsequently, we have a mixture of that is termed as DIC, where both procoagulation and anticoagulation mechanisms are working together. So in these patients, the patients are at risk of both, either bleeding or causing DVT. Now coming to management of sepsis, the 1R bundle. So first we need to identify sepsis. There are various scores that are available, such as SOFA, NEWS, and MUSE and SIRS. With the recent guidelines, the QSOFA has not been recommended as a single tool for identifying sepsis. So what is the R1 bundle? So sepsis needs to be treated as a medical emergency. And the first thing that needs to be undertaken is measuring lactate levels. So lactate is one of the markers of hypovolemia, or you can say hypoxic tissue injury. So an elevated lactate more than 2 mmol per liter is an indicator of sepsis. Then followed by obtaining blood cultures before administering antibiotics. This is the most crucial part, that so that we can identify the organism that has caused the infection before prior to administering the antibiotics. So once the bacterial culture is taken, the next step is administering as soon as possible broad spectrum antibiotics, because we don't know which bacteria is leading to the cause for the sepsis. And it will be subsequently discussed later which factors and what all to consider while choosing broad spectrum antibiotics. The next step is rapid administration of fluids, particularly crystalloids. And the dose that has been described is 30 ml per kg for hypertension in cases of lactate where more than 4 mmol per liter. And if still the blood pressure is not being managed, the hemodynamics have not been managed, we can use vasopressors for this hypertension to maintain a mean arterial pressure of more than or equal to 65 mmHg. So lactate. Lactate is a biomarker of tissue hypoxia and dysfunction. It also is a marker of severity or mortality. The normal levels are not achieved in all patients and cannot be targeted while resuscitation. But yes, a lot of studies have proven that targeting lactate levels, reducing the lactate levels in the early period is a good sign of reduced mortality. But lactate alone cannot be used as a marker, and it has to be cautiously read, because it can not be just increased in sepsis, but it can increase in glucose metabolism, or through medications such as use of epinephrine, metformin, the nucleoside reverse transcriptase inhibitors, and also when poisons has been consumed like ethylene glycol and methanol. It is not just the production of lactate that can lead to the increased levels, but it can get decreased clearance, such as in cases of liver dysfunction or cardiac surgery. But measuring lactate is not available each and every time. What about in cases of resource limited settings? So in these cases, measuring lactate may not be available. So how we will uh, evaluate the patient in such cases? So let's see. The first, what are the resuscitation targets? The aim of the resuscitation target is restoring of the intravascular volume. We have seen, because of the capillary leak, all the volume that was there in the intravascular volume has come out and into the extravascular compartment. Now, because of this, the cardiac output has decreased. So we need to target that as well. Because of that, after increasing the cardiac output, we can augment the O2 delivery and hence improve the tissue oxygenation. But delivery of oxygen supply cannot always mean that the oxygen extraction by tissues is there. So what are our aims while resuscitating? So in the main target is mean arterial pressure, 60, that is more than or equal to 65 mmHg, decrease in lactate levels of 20% every 2 hours for the first 8 hours, or reduction in capillary refill time less than 3 seconds, or a urine output of more than 0.5 ml per kg per hour. So we have capillary refill time in resource limited settings where pressure is applied on the fingertip, and we wait for 10 seconds to blood to withdraw from there. And after releasing, if we see the blood coming in back into the fingertip is less than 3 seconds, then we have achieved our resuscitation target. So now the antibiotic therapy in sepsis. So there's a case of 57-year-old female with diabetes who presents with pain in left calf after fall from vehicle. She is febrile, tachycardic, look ill, and her calf is tender to touch. The skin overlying the left leg has many bulla with black necrosis. Her initial blood pressure is 83 by 47 with the lactates of 6.2. So yes, she's in sepsis. Despite repeated efforts for about an hour, the phlebotomist is unable to draw blood cultures. Swab cultures were sent from the site for the first bulla. The patient has been in the hospital for about 3 hours now. So which of the following is the best next step in the management of the patient? So are we going to wait for the patient blood cultures to be taken out? Should the phlebotomist keep attempting further blood culture chances? So let's see. So in this case, we see antibiotic administration is a most crucial thing. Yes, microbiologic cultures is also again crucial so that we can identify the organism and start appropriate antibiotics. And in patients with shock, it is very crucial to be initiated within the first hour of recognition. So delay leads to increased in-hospital mortality. And further, in case of if the shock is absent, there is some time that patient can give us time. So the time period 3 hours. Once we can evaluate, we can assess the patient again and see if the sepsis is present. If not, we can avoid the use of unnecessary antibiotics. So what are the biomarkers to start or stop antibiotics? So there's procalcitonin is present, CRP is there, but the recent recommendations have not justified its use as a marker for initiating a therapy, or whether it will tell us the time to initiate what time we could start an antibiotic. So now in this case that we saw, the patient was in shock. So we needed to start the antibiotic within 1 hour, and it has already been an hour. So we'll administer the antibiotics despite the possibility of blood cultures being negative thereafter. We already have the swab culture for this patient. So there is a chance that we might get some clue towards what bacteria or other organism that might be growing. Although it is essential that blood cultures should be drawn with other microbiological cultures. So now what criterias or what factors one should consider while selecting an antibiotic? So first is the age and comorbidities. The second is the patient history, where the patient has taken any recent medications. So any recent antibiotics that could, you know, change your view on which further antibiotics to choose. Any allergies. So your choice again will change if the patient is penicillin allergic or cephalosporin allergic, then followed by organ dysfunction. So certain antibiotics might get eliminated from that particular organ like kidney or liver, and you might want to choose a safer option. Presence of invasive devices again gives you a clue what kind of bacteria that might be growing. So immune status, again, your selection, the duration of therapy will change accordingly. The site of infection, so that you can choose an appropriate antibiotic that penetrates that particular site of infection. The epidemiologic factors, what are the trends of infection? What are the trends of the resistance in your particular setting? It might not be the same in each and every setting. It might vary from state to state or country to country. Then further, the PKPD considerations. Not all patients respond similarly to all antibiotics because of the differences in the pharmacokinetics and pharmacodynamics. Now, again, the combination therapy for coverage of suspected multiple pathogens is discouraged. So, risk factors for resistant pathogens. So, recent antibiotic use, recent hospitalization or ICU stay, recent surgery, again, a possible use of surgical prophylaxis antibiotic, previous infection or colonization, a MRSA colonization perhaps, a central venous catheter or indwelling catheter, or any other invasive devices, a history of hematopoietic stem cell transplant or a solid organ transplant, injection drug users, immunosuppression, and hemodialysis. So all these cases can uh, contribute towards a resistant pathogen growing in. The PKPD consideration, mostly in the changes in the volume of distribution and the clearance of drugs, should be considered each and every time while prescribing an antibiotic. So we can see from all the changes how the variations in extracellular fluid is increased. We can see how the clearances of the various antibiotics can get affected, and all these factors should be considered in while choosing an antibiotic. And again, the PKPD targets and strategies, like for the aminoglycosides, AUC, Cmax, carbapenems, time more than MICs, cephalosporin, again, time more than MICs, and vancomycin, AUC in the 24 hours, fluoroquinolones, again, AUC. So accordingly, the dosing should be considered to meet the targets and show that appropriate microbial killing is ensured. So after initiating an antibiotic, antimicrobial de-escalation should be done on a daily basis. So an assessment to see whether the antibiotic can be de-escalated either by stopping it when it is no longer necessary, when we have a negative culture, plus we have the other assessment pointing that it is not sepsis, changing to a narrow spectrum when we know what are the lab cultures showing. The microbiology result documentation, invasive sampling, lower baseline severity, and clinical resolution and culture positivity all help in the early de-escalation of antibiotics. Whereas polymicrobial infection, multi-drug resistant organisms, infection associated with low probability of positive microbiology, inadequate initial antimicrobial therapy, lack of microbiological documentation, and initial appropriate antibiotic that could not be de-escalated to narrow spectrum activity. These all points towards the negative points of de-escalations. So how long can we give an antibiotic? Now, with the recent recommendations, recent data that has come up, they suggest a shorter therapy even in cases of HAP, VAP, and uncomplicated cellulitis. Whereas longer therapies in undrainable foci, bacteremia, MRSA, candidemia, or invasive candidiasis. And it also depends on whether adequate source control was achieved or not. Another help, like I said, procalcitonin, not a good marker for initiation, but yes, definitely a good marker has been as a good marker for de-escalation of antibiotics when its value falls less than or equal to 0.5 nanogram per meter per ml or an 80% decline from the peak. So yes, definitely an initial procalcitonin levels should be done when suspecting sepsis so that it can help further in the de-escalation of antibiotics. So now we have the same case. The patient's skin overlying the left leg has many bulla with plaque necrosis. There is a serosanguinous discharge. The distal pulses have decreased and there is crepitus. She started on broad spectrum antibiotics. So now what is the next step, best step in the management? So either we continue the same and monitor for the response and obtain an X-ray to look for subcutaneous gas, perform ultrasound to rule out DVT or emergent operative debridement. So like I said, source control, once it is achieved, then only we can de-escalate an antibiotic. Now, why is it is important? Because if the source of infection still persists, the antibiotics alone will not take care of it. The drainage, the abscesses, the cellulitis will continue and keep on affecting the individual. And it can also lead to the secondary bacteremia. So unless and until the appropriate source control is established, we cannot further downgrade or de-escalate our antibiotics. The source control can be either less invasive or it can be a surgical invasion, like in drainage of brain abscesses. So yes, an emergent operative debridement is necessary for this patient. Now coming on to the fluid therapy in sepsis. So what are the fluid choices that we have in our hands? The first is the crystalloids, which is composed of water, electrolytes, and sugar, glucose. Colloids, on the other hand, mostly is comprised of albumin and blood products. So albumin has been also suggested for initial resuscitation if large volume of crystalloids is required. But starch, gelatin, and dextran have been not recommended. Now, all these fluids have their properties different to each other. Firstly, the osmolality is different in each of these fluid compositions. The sodium levels vary, the chloride levels vary. The potassium, calcium content mostly absent in most, but present in balanced salt solutions. So now what happens when we give this fluid? So just to understand this, we have a total body water 60%, right? From the so if we consider 70 kg percent, this total body water will be 42 liters. In that, the intracellular fluid will be 28 liters, extracellular fluid will be 14 liters, which is further subdivided into intravascular and interstitial fluids. What happens when you give normal saline? So 1 liter of normal saline gets completely distributed in the extracellular fluid, but it only remains 1/4. So only 250 ml gets remain in the intravascular, other gets eliminated into the interstitial. What happens when we give dextrose? So only 83 ml is remaining in the intravascular volume. So our main target for accomplishing a good fluid resuscitation strategy is providing fluid in the intravascular volume. It is pertinent that this fluid remains in the intravascular volume. So now for this patient has developed VAP. Her blood cultures and ET secretions were obtained and appropriate antibiotics were started. Her initial blood pressure was 83 by 47 mmHg with a lactate of 6.2 mmol per liter. She was given 1 liter of NS over 1 hour. Subsequently, her blood pressure improved but not much, 92 by 54, with a lactate of 4.6 and a urine output of 30 ml per hour. Labs HB was 9.2 gram per DL, TLC 14,700, what would be the best therapy for this patient right now? Her weight is 66 kg. Should we choose NS? Should we choose 5% albumin? Or should we go on with the vasopressors? Or does she require a blood transfusion? So fluid resuscitation. So initial resuscitation is being recommended with crystalloids, and a dose that has been prescribed through various trials that have been conducted. They have found better mortality benefits with this particular dose of 30 ml per kg within 3 hours of sepsis onset. But although this number is there, it should be individualized for each and every patient, as each patient is not the same. It could be an old versus young patient, obese versus frail patient. A fluid bolus is the rapid infusion of fluids over a short period of time, typically 500 to 1000 ml, and a fluid challenge that we give to check whether the patient is responsive to the fluid is 4 ml per kg or 250 ml fluid in 10 minutes. So now we can see that she was only provided 1 liter of NS. Her weight is 66 kg. So the proper if we consider 30 ml per kg fluid, it will come around 2 liters of fluid. So again, she has not received, and the initial choice, obviously a crystalloid, is NS. So no other colloid nor vasopressor is required right now because we have not achieved the fluid resuscitation appropriately. Now the patient has developed VAP. She subsequently develops hypotension, tachycardia. Her ABG shows 7.24. Lab values of sodium 142, chloride of 111, potassium of 3.5, bicarb of 19, creat of 2.1, and albumin of 3.3. So now what will be the choice of the fluid for the initial resuscitation now? Will we give NS again? Will we use a sodium plus dextrose combination? Or will we turn towards a colloid or a balanced salt solution? So not always NS is a good thing. There are some harms. So which is hypochloremic metabolic acidosis, which is defined as chloride more than 107 milligrams per liter, a pH of less than 7.35. It can also cause renal vasoconstriction, which leads to AKI and further requiring a renal replacement therapy. So this further led to the formation of balanced salt solution. Although the evidence has been weak and of low quality, the SALT trial and SMART trial, they have shown that balanced salt solutions have mortality benefits and have reduces the incidence of hypochloremic metabolic acidosis and the incidences of AKI because of its net less chloride in the solution. But again, the question arises whether it is cost effective. So because NS is cheaper as compared to plasmalite, so can we rely and is it a cost effective solution? In this case, we have a chloride level of 111. Again, patient is showing signs, ABG shows a pH of 7.24. She's definitely into hyperchloremic metabolic acidosis. So we cannot go further with NS. We cannot give NS plus dextrose. Again, the fluid will not be sufficient enough. 5% albumin. The albumin levels are all right, 3.3. So a balanced salt solution such as plasmalite would be the answer. So role of albumin in resuscitation. So maintaining a fluid balance, it helps in maintaining the fluid balance between intra and extracellular space. Because of its colloid osmotic pressure, it maintains the fluid in the intravascular space. It can also help in the transport of various medications, vitamins, and amino acids. So, and while giving albumin, we don't have to give a lot of fluid volume. When to consider in sepsis, that is when large volume resuscitation is required with crystalloids and the albumin levels have gone down more than 3 gram per dl. But again, the cost is one of the factors, especially when considering resource limited settings because of the cost of albumin. Now, how do we measure the responsiveness whether patient is responding to the fluids and whether it is tolerating that fluid amount? In these cases, dynamic measures are used as compared to the static measures. The static measures only measure the preload and hence cardiac output. These measures are central venous pressure, which should be more than 8 mmFg, pulmonary artery occlusion pressure, global end diastolic volume, and the IVC diameter that we measure through 2D echo. The dynamic measures that we measure are stroke volume variation, pulse pressure variation, the passive leg raise test, and the fluid challenge. Now, the fluid strategies that are implemented are further. First, we saw the resuscitation fluids, then comes the maintenance fluids that is required. So, on a daily basis, water is required in the range of 25 to 30 ml per kg in 24 hours, potassium 1 to 1.5 mmol per kg, sodium 1 to 1.5 mmol per kg, dextrose 1.4 to 1.6 gram to avoid starvation ketosis. Now, obviously, this is required when the patient is not taking any oral food. So we need to supplement through the IV way. Then replacement fluids, where there is loss of lot of fluids through drains, stomas, fistulas, or probably because of fever, open wounds, and polyuria. There are also nutrition fluids that we give, like TPN. So harms of fluid. We need to have a control of how much fluids we give. Otherwise, just this is an example of what happens in the abdominal vasculature. So the fluid resuscitation, if excessive, can lead to intestinal edema, cause visceral swelling, intra-abdominal hypertension occurs, and further this leads to more of a elimination of fluid by the kidneys. But it also leads to the mesenteric vein compression and venous hypertension. So all things are poison and nothing is without poison. Only the dose permits something not to be poisonous. Now, once we have given fluids, now when to start a vasopressor if the patient is still not responding? So after the initial fluid resuscitation of 2 liters of NS, now that we see we've given a good initial fluid resuscitation, 45 minutes after giving fluids, her BP is still 91 by 53 and lactate of 4.7. Urine output is 30 ml per hour. What would be the best therapy for the patient now? Should we give more fluid of 500 ml? Should we start norepinephrine or start dopamine infusion or start vasopressin? What vasopressor or should we go for fluids? So when to start norepinephrine? So it is the first choice. In all the vasopressors, it is the first choice. It should be come straight into the mind when thinking of starting a vasopressor. So we can initiate after hypertension, which is not responsive to the fluid administration. And once we start norepinephrine, we see the response, and if it's still the patient is not responding, we can further add vasopressin. As we had seen in the pathophysiology also, there is a sufficient vasopressin deficiency that can occur in later on stages. So when the patient is still hypotensive on norepinephrine doses of 0.25 to 0.5 mics per kg per minute, we can start vasopressin. Epinephrine further is the further choice, even after hypertension or norepinephrine doses and vasopressin. So here we will start norepinephrine. We don't want to patient to be in a hypotensive state for a long time. So some vasopressor pearls that I would like to share. The early start limit the harmful effects of fluid and organ hypoperfusion. So again, by giving, if you would have given more fluid in that case, the fluid overload could have been occurring. Norepinephrine is more potent and less tachycardic. Vasopressin is again a catecholamine sparing. So we don't have to go very high doses of norepinephrine, which can save us some adverse effects of those catecholamines. And just we have to be careful with peripheral ischemia that can occur with the vasoconstriction with vasopressin. Dobutamine has more of a role in cardiac dysfunction, but it is also more arrhythmogenic. Epinephrine has more of a role in mixed cardiogenic shock or shock not responding adequately to norepinephrine and vasopressin. But also need to make sure that it causes hyperlactemia, tachyarrhythmias, and hyperglycemia. So cautious use of epinephrine as well. Some properties of various vasopressors like norepinephrine, the kind of receptors that it acts on, the dosage, and what are the changes that it affects on the cardiac output and heart rate. So the patient is now receiving norepinephrine of 8 mics per minute. So we had started the fluid, we have given the fluid, now we have given started vasopressor. Her vitals and lab values, blood pressure 100 by 60, heart rate 90, MAPS 62. Now what to do next? So do we administer hydrocortisone here as a either intermittent bolus or as a continuous infusion? Or should we see whether there is a deficiency in cortisol levels or is no steroid necessary in this case. So the role of steroids in sepsis, it is an anti-inflammatory, and because in sepsis there can be also a depression in the adrenal, there be a relative adrenal insufficiency, and it also stops vasodilation. So when can we start? So at least after 4 hours of norepinephrine dose of more than 0.25 mics per kg per minute. The dose is 200 mg per day, as a loading dose can be given and followed by 50 mg every 6 hours. The target map is more than 65 mmHg, but it comes with its adverse effects such as hyperglycemia, hypernatremia, neuromuscular weakness, and adrenal insufficiency secondary. So in the 2024 guidelines, it suggested steroid in patients with septic shock, but against a high dose or short duration of more than 400 mg per day of hydrocortisone, equivalent for less than 3 days. So in our case, she's maintained her map somewhat, and still we have not uh, reached to an optimal level of norepinephrine dose. So in this case, if we want to increase the map, if we want to increase the BP, we can still go higher up with the norepinephrine dose because it is very minimal. Now, other therapies that we need to consider in sepsis are such as intermittent boluses of neuromuscular blockers for sepsis-induced ARDS in patients who are mechanically ventilated, blood and blood products in cases of anemia simultaneously present so that the optimal oxygen delivery is there. If hemoglobin is not present in adequate quantities, we cannot achieve a proper O2 delivery, even though when we have resuscitated a lot of fluids, because it is the blood, it is the hemoglobin that delivers the oxygen to the end organ. Then followed, because in sepsis is a stress causing phenomena, we need stress ulcer prophylaxis, or else there can be generation of bleeding ulcers. So the choice of drugs is either pantoprazole or ranitidine, but majorly it is in the recent studies it has been pointed that pantoprazole is more effective, although some considerations towards increased risk of C. diff and VAP. Now, venous thromboembolism prophylaxis. As we have seen in the pathophysiology, DIC can occur, more coagulopathy, microthrombi, and thrombosis all lead to the increased risk of DVT and pulmonary embolism. So, low molecular weight heparin, majorly enoxaparin is used at a dose of 40 mg once daily, but again, the mg per kg on the basis of weight, how much patient is obese or not, the dose should be considered. Also, insulin levels and sugar levels, glucose control is very important in patients with sepsis. It helps if the glucose levels are dearranged in these patients, the mortality benefits might not be shown. The patient might even have further troubles in recovering from sepsis. So, a glucose target with insulin usage of 144 to 180. We do not use OHs in these cases. Again, we can see from the previous slides that we are seeing, metformin, again, if we give, it can lead to higher lactate levels, and certain OHs again get accumulated in organ dysfunction as well. So insulin is an ideal choice in maintaining the glucose control. Other therapies like immunoglobulins, again, not suggested. Vitamin C, not suggested, but there have been certain conflicting data again. Methylene blue, newer studies are coming up, whether, so still a conflicted topic over there, methylene blue use. Then sodium bicarbonate, again, septic shock present with severe metabolic acidemia and AKI is an indication for sodium bicarbonate, and not to just correct shock and hypoperfusion induced by lactic acidosis. And also early nutrition initiation within 72 hours. Again, it helps in a good gut microbiota so that further gut bacterial sepsis secondary to that cannot occur. So first with the infection, then with sepsis, and as the patient develops septic shock and multi-organ dysfunction, the mortality keeps on rising. So we have to make sure that we stop the sepsis worsening further, and we should take corrective actions as soon as possible. So just a recap of what all we need to take care in sepsis patients: early antibiotics, the correct amount of fluids, the vasopressors if the fluids have not achieve their aim uh, of regulating the hemodynamics, then initiating enteral feeding with supplements of insulin therapy if required, deep sedation not required, low molecular weight for DVT prophylaxis, lung protective ventilation in cases of ARDS, source control to rapidly, we should identify the microbiological source for it and also control it. And so all the further hemodynamic measurements along with this to help our patient in sepsis. So key takeaways. Early identification of sepsis and immediate initiation of treatment can be achieved with the help of 1 hour and 3 hour bundle. The blood cultures prior to antibiotic administration, antibiotic start within 1 hour of sepsis. Antibiotic dosing and administrations to be optimized as per the PKPD alterations that occur in sepsis. Fluid resuscitation should be followed by the initiation of vasopressors if required, if the hemodynamic targets are not achieved first. The first choice is norepinephrine followed by vasopressin plus or minus epinephrine. Fluid administration should be individualized as it may prove to be deleterious if not used judiciously. Steroids, when hemodynamic targets are not achieved even after 4 hours of norepinephrine dose more than 0.25 mics per kg per minute. So, if further references uh, to help out in getting a better understanding towards sepsis and septic shock. So, further, we have a few presentations coming. First one is tomorrow in the cycle 2 of our infectious disease module. So, antimicrobial allergies by Nishala Reddy. Second presentation on 28th of April, 7 p.m. by Asha Sana on clinically significant antimicrobial interactions. We have again a penetration of antibiotics to different body sites on May 5th, 2024, 11 a.m. to 12 p.m. by Survi Dupad. And the top papers in critical care medicine on May 8th, 2024, 5 p.m. to 6 p.m. by Dr. Rajan Barokar. Thank you.
Yeah, Abhay, that was a very good presentation, Abhay.
Thank you, Akash.
So we have covered everything what we want to know about sepsis and septic shock in this module. I just want to have some discussions about our question answer session. So if anybody has
Yes.
any questions, they can just post it over there. What I would like to ask is, so hydrocortisone can be started when actually patients require at least two vasopressor septics. That is what is currently recommended. When should this infusion be actually stopped?
So you didn't get the last part?
So, like, we can start steroids when patients
Yes.
require high dose of vasopressors and septic shock, actually.
Yes. Yes.
When can actually this hydrocortisone be stopped in such patients?
When can we stop?
Yeah,
The duration, I think so. I'm not sure about how the duration regarding the stoppage of steroids as of now. I'll get back to you on that. Yeah. But
usually, actually,
initially, yeah,
what they have actually found out is the initiation of steroids is when the second vasopressor actually comes in, when the patient requires. So, and it is a very low dose of steroids. It's only
yes,
50 mg every 6 hours or every 200 mg per day. So it
yes,
steroids can come off actually when once your second vasopressor has come off and NORAD has been at least gone down to like point 0.1 to point 0.2 sites. That is what certain studies says. That is what we have been also practicing over here.
yes. Correct. I think so. It is also justified that when the doses are going down of norepinephrine, that why we choose hydrocortisone is because of the cortisol deficiency that occurs. So in the initial stages of sepsis, we have a high usage of cortisol. So the body utilizes it rapidly, and then we have a depleted store, right? So in that cases, again, the vasodilation is because of possibly because of the cortisol insufficiency, and it plays a major role in maintaining the hemodynamics, or we can say the vasculature blood pressures to a normal range. But because of this deficiency, uh, uh, the blood pressure cannot be maintained. So yes, once we can see the target that the cortisol levels are appropriate and the body can manage on its own, which we can rightly see when the norepinephrine doses go down, we can stop the steroid dose.
One more this thing is like as a clinical pharmacist. So we have talked about management of septic shock in detail. What do you think when like as a clinical pharmacist, the most what are the things which we can give the priority to most? Like when a patient who has onset of septic shock, as a clinical pharmacist, what all can we give priority to?
Yeah. So I think so the first priority, like in any management of sepsis, is the administration of antibiotic and the time of antibiotic administration. But prior to that, always making sure that, okay, whether the team has taken any microbiological cultures or not. And one can also, plan in their formulary what kind of antibiotics that they're going to have in their hospital or in their ICU stored, so that when a patient or an emergency department, so when a patient comes in with sepsis, you are all ready for that challenge. You have all your tools with you, and you can start a rapid response towards that emergency. So quick microbiological cultures, imparting knowledge to all your colleagues who are there, who are treating that patient, know how important the microbiological culture is, what kind of blood culture sets to be taken, and identifying the source also, whether, what kind of source with the history, patient's history, we can identify, kind of gives a picture which site are we targeting. And once we know that, we can also suggest a dose of antibiotics plus all the changes that we see in the patients, whether the blood pressure, how is it, whether we're going to give fluid, how much of fluids. So accordingly, changes in the PKPD that are going to occur, that will again we can suggest the dose optimization, whether how much of loading dose or the maintenance dose that subsequently that needs to be started.
So as we all know, septic shock can have a very bad impact on the coagulability, like as we have discussed, according to the pathophysiology of septic shock. So one thing is that it is also prothrombotic state when a patient actually presents with septic shock. On the other hand, there's also that it can also lead to DIC. So what are your takes on like initiation of a DVT prophylaxis? So should we initiate at the first day when the patient presents itself, or should we actually wait for at least 24 hours, see how the platelets are going, or see how the INR is trending? Because it can very well lead to DIC also. So what do you think of?
Yeah, I think so. One should also consider the risk factors other than sepsis also if present, which can, further affect a prothrombotic state. So if those factors are still present, like any cardiac issues, any previous history of DVT or PE, any airplane travel, which can further lead to stasis. So if that is there, I think so, no need to further consider in a delay of DVT prophylaxis. But yes, and I would wait for the lab results to come in, because if we have a low HB in the patient or a low platelet count, and if we give even the DVT prophylaxis dose, the patient can bleed. So in these cases, a cautious approach. Once the lab results are in, whether if there is a history of patient taking any anticoagulants, again, one should ask that in the history as well, and then decide whether after 24 hours to start on the DVT prophylaxis or not.
In such cases, if a patient is in a severe septic shock, so when the peripheries are all cold and clammy, as we know, including the skin, so where absorption of subcutaneous drugs are very difficult or is questionable, is low molecular weight heparins a very good option for suggesting DVT prophylaxis for such patients?
That again becomes tricky. Yes, definitely. We have in the PKPD studies, there was a decrease in absorption, but not quite. But if it still needs to be administered, we know that we cannot to the subcutaneous site, we can definitely give IV as well. I know it's not a recommended thing as of now, but that is also an option that can be there. But yes, not much subcutaneous absorption is affected as such. So I think so dose optimization and again monitoring the therapy of LMWH with APTT monitoring. I know it is not available everywhere, but other blood parameters should be checked so that we know that we have a working therapy in our hands.
So about the blood glucose levels. So as we all know that if the patient is a diabetic or not, there is a stress response also. Patients can present with hyperglycemia, but also on the other hand, septic shock when body is in a state of shock, when it is trying to, when it is state of catabolism also, and when the resources are limited, that time patients can they tend to develop hypoglycemia also. So in those cases, the varying blood sugar levels, I think, can is also to be looked upon very closely.
Yeah. So I think so with there was a recent article as well on this, whether a lot of debate has been going on for this. So whether to a tight control of glucose. So again, when the resource limited setting where we don't have that much of measuring, frequency, we do not one should not aim for a tight control. We can accept a range of 140 to 180 and not beyond 180, but yes, also not less than 140. So a tight control is like maintaining a blood glucose in between 120 to 140. So that is a very tight control of glucose, and it has had more chances of developing hypoglycemic events. So I think so with that, I hope it answers your question. And at times, to avoid starvation also, we give dextrose and other nutrition therapy as well. So in that also, it can further add to the hyperglycemia. So insulin and glucose control should be matched, but not a tight control, very tight control, so that hypoglycemic events occurs.
Thank you so much, Abhay. Thank you so much for FCFI also for
Yes.
providing us this opportunity. It has been a great session, and I think this session has actually covered all the things that is required for the management of septic shock in a critically ill patient. So thank you, Abhay.
Thank you, Akash. Thank you so much for the patient listeners.